Well, hi everybody. Thank you for having us out here this afternoon. And as Josh said, we really wanted to take this opportunity to talk to you about our innovative approach to taking care of patients in our communities who have diabetes. And it's really not so much about new technologies and new scientific discoveries, although that is part of it. Really, it's more about our partnership and teamwork and collaboration and really coming together around our patients in completely new ways to take the best care of them possible.
Okay. So we can't start talking about diabetes without thinking about the prevalence of diabetes in the United States. So what this slide shows you is, this is from the Centers for Disease Control, is that there's around 26 million people in the United States who have diabetes, but only 19 million of those are actually diagnosed. And there's another 7 million who are undiagnosed. So diabetes is on the rise, which all of you know. In fact, a lot of people say that it's epidemic proportions now. So think about it in another way. There's 1.9 million Americans every year who are newly diagnosed with diabetes. If you average that out, that's over 5,200 people a day that finds out they have diabetes.
So when you look at the costs associated with diabetes, obviously it's huge. So $176 billion are related to direct medical costs associated with diabetes. So that's looking at things like medications, hospitalizations for diabetic patients, all the diagnostic studies that need to happen. And then you have the other 28%, which is related to indirect costs associated with diabetes. And that's a whopping $69 billion on an annual basis. And those are things such as absenteeism, loss of productivity at work, inability to focus and completely be present for the job that individuals need to do. So, you know, this is the money slide, talking about the tremendous financial and economic impact of diabetes, but that's really small compared to the effect that diabetes has on our nation as a whole and on our communities. I'm sure every one of you, whether you're a diabetic yourself, you probably know someone who has diabetes or has a family member with diabetes. It's a tremendous personal toll in addition to the economic costs.
So let's drill down just a little bit more and look at what diabetes looks like in the state of Texas. You have about almost a 10% diabetes prevalence, which actually is higher than the nation's average, which is around 8.3%. So that means that 1.8 million people, Texans, living in the state of Texas actually have diabetes. So you can see the numbers there in terms of the economic toll for the state of Texas. You spend annually $18.5 billion on treating patients with diabetes. You can see that 12.3 of that is related to those direct costs like Dr. Ransoms were talking about. So it's the hospitalizations, which makes up the majority of that. But it's also physician office visits, and it's the medications to treat diabetes. And then you have the indirect cost, which is another $6.2 billion. And that's more things like lost productivity, absenteeism from work, those types of things.
So our experience here at Texas Health Resources is pretty reflective of what's going on all around us. We are pretty much right at the center of the storm for diabetes and the obesity epidemic nationally. And certainly we see that every day in our hospitals and in our communities and in the patients that we take care of. So if you look at our hospitals and our patients who are staying there and we're taking care of, we have a range on the low end of 18% of inpatients have diabetes, and I believe that's at our Plano hospital, all the way up to a high of 32% of our inpatients have diabetes, and I believe that's at Azle. In addition to just the overall costs associated with diabetes, what we find is that our diabetic patients stay longer in the hospital. So for example, for a patient who may have a fractured hip, if they have diabetes, then they'll stay longer than their counterpart who doesn't. And that happens across the nation. That's not just a THR, but certainly we see and have that experience as well. Readmission rates are also higher for our patients with diabetes. Again, when comparing the patient with the same diagnosis, those who have diabetes are much more likely to be readmitted than those who don't. So really, this gets to the heart of how and why we're doing this. It's really about our partnership and developing new ways to care for patients. And again, at the heart of all of what we do is our mission, and really that's to take care and improve the health of patients and people in the communities that we serve.
And Healthway's mission is to create a healthier world one person at a time. So you can see the synergies between the two organizations and therefore our partnership around diabetes. Which leads us into the next slide. About 16 months ago, I think now, we actually started a system-wide diabetes initiative at Texas Health. So what we did was we started with putting together some committees of interdisciplinary. They were very collaborative committees. The first one we started with actually was our steering committee. Now you'll hear me refer to that as our CDC steering committee. That is not to be confused with Centers for Disease Control. We refer to CDC as Comprehensive Diabetes Care.
We thought everybody would remember it that way,
Yes.
so that's what we started with.
Sometimes I think they're a little intimidated when we say that, but anyway, so the CDC steering committee was made up of your system level leaders, and these are the people who are going to have oversight for this system-wide initiative. In addition to that, we've developed diabetes work groups. And again, these are made up of certified diabetes educators, of pharmacists, of physicians, and we have two of those. One is focused on inpatient processes. And with the inpatient processes, our goal is to standardize glycemic management of the patient if they have to come into the hospital. The outpatient diabetes work group is really about standardizing processes around patient education and curriculums, and how do we make it easy for the physicians to refer to those diabetes centers that we already have. One other committee that we've actually just put into place a couple of months ago are the diabetes resource teams, and some of you in here may be a member of that team. The diabetes resource teams are going to be made up of diabetes champions within each hospital. So we're working with the 14 wholly owned hospitals right now, and we've developed these diabetes champion teams. And so you'll hear more about that in just a minute.
So really the idea is that partnership cascades down into collaboration among teams and into interdisciplinary ways. So as we started out with this, we realized that in order to standardize, we really needed to get all of our staff and employees on the same level and on the same playing field. So initially we wanted to do an assessment to see where we were, and that was a nursing skills assessment that all of our inpatient nurses underwent. And then following that, all of our nurses, 5,000 plus of our inpatient nurses, underwent a 2-hour face-to-face educational program. And then following that, 250 of our diabetes resource team members that Sheila talked about underwent a 4-hour face-to-face training as well. And then finally, we realized that physicians are obviously a key component to taking care of our patients, and we really wouldn't get any traction unless they were leading the charge and involved with us. So we have a curriculum for our hospitalist physicians that, as a matter of fact, our Texas Health Physician Group, or THPG, has mandated that all of their hospitals go through this curriculum that's directly linked to what our nurses have learned, what our diabetes resource team members have learned, so that we're all working with our patients in the same way based on the most current and up-to-date evidence.
So in addition to the professional education, we had to focus on the patient. And so we've worked collaboratively to develop some new patient education resources. So Healthways and THR got together, and we actually have developed both an inpatient piece, which is the one on your left. And so basically what it is, it's a piece for the nurse to give at the bedside. And it's not as comprehensive as the other piece that you see up there, because that's really for the outpatient setting. So we have developed both of those, and I'm pleased to say that those inpatient pieces are available now, and you should see them at your entities.
Really the idea is so that if a patient shows up in Plano or Azle or Stephenville, they're getting the same top flight experience around their diabetes care. And it really comes down to what is the most up-to-date treatments and recommendations that are available and that are out there. So again, as I said earlier, we really needed to engage with our physicians around this, and we have a physician task force that really focuses on the orders around medication orders and inpatient orders around the care of all of our diabetic patients. So we started off with a hypoglycemia order set. That's if a patient's blood sugar drops too low. That is now standardized across our entire system. We also found that not all of our patients were getting what's called a hemoglobin A1C test. That looks at sort of long-term control of blood glucose, and it's a very important measure for diabetics. And on the outpatient side, many primary care physicians were finding that our patients hadn't gotten this level. So we thought it was incumbent on us, even though maybe we didn't need this value on the inpatient side, but we mandated that all our patients who had glycemic order sets needed to get a hemoglobin A1C drawn. We also coordinated with our heart and vascular group to make sure that their glycemic order sets were in line with the current recommendations around glycemic management. And then we're also piloting new initiatives around carb-based insulin protocols.
So what are some of the accomplishments that we've had so far? You've heard us talk about, we've been working on this initiative for about 16 months now. Well, Texas Health already had 6 ADA recognized centers. So for those of you who are not aware, an ADA recognized center is really a center that's received a gold seal from the American Diabetes Association. So you had 6 of those already. But when we geographically looked at the area, we thought you probably needed to add a couple more. So I'm pleased to say that in Plano, just last month, we opened up a new diabetes education center, and they've already received that ADA recognition and are now seeing patients. So in addition to that, we'll be opening up another outpatient center in the Denton area. And so that process and that work is just beginning. So I don't have a date on that just yet. So we also looked at websites. So if a person in the community clicks on and does a search around diabetes, we wanted to make sure that the website for Texas Health was, first of all, had great information, and then of course to provide them a link to our outpatient centers too. So we've added a patient risk assessment to the website. So if a patient's in the community and they want to know, am I at risk for diabetes, they actually can click on the link, answer a couple of questions, and it will give them an assessment of whether or not they are at high risk, low risk, or medium risk for developing diabetes. And then of course, as I mentioned, there is that link that if they need to go to an outpatient center, that's there too. So one of our overall goals is certainly to improve the clinical outcomes of the patients who have diabetes, but in addition to that, inside the hospital, it's also to decrease medication errors related to insulin. Most of you know in this room that insulin is a high-risk medication, so we're working to help reduce those medication errors too, but while also improving patient satisfaction.
So this is looking at some of our actual clinical results and really around glycemic control. And what that means is that you want patients' blood sugars to get closer and closer to the goal targets. And if you look at that top line, the black dashed line, that steady increase that you're seeing is the proportion of patients whose glucose values have been in range. And that's ever since the partnership with Healthways that we've seen that. Next slide. So additionally, as Sheila mentioned, insulin is considered a high-risk medication, and that's because if too much insulin is given, the greatest risk there is patients can become dizzy, feel nauseous, even lose consciousness, fall into a coma, and in worst-case scenarios, if they receive too much insulin, death can result. So it's something that we always track. If you look around the country, insulin errors are always in the top 10 in any hospital that you look at. For the first time in 2013, insulin dropped to 12th place in our insulin-related medication errors in our hospitals, which is really, frankly, a huge accomplishment. And in fact, there's overall been an 83% drop in medication errors related to insulin.
So one thing that we didn't want to lose sight of, though, as we were doing all these initiatives and making all these changes, is the patient. So one thing we've been tracking is patient satisfaction as it relates to the outpatient centers. So these are results for the past 2 years, and you can see there's been a steady increase that we're pleased to report in patient satisfaction as they're polled by Press Ganey.
So really, the goal of our program is to look at diabetes in a new way and look at care from a new paradigm where it's partnering with organizations who have the expertise to help us accomplish what we need to. It's partnering with our patients and with our clinicians with the ultimate goal of improving care of our patients in our communities. So thank you for having us.